Hello, friends. I will be giving a three-part series of talk on movement disorders on the Parkinson's disease clinical approach today. In the next part on atypical Parkinson's syndrome, and in the part 3, treatment for Parkinson's disease and movement disorders overall. I am Partha, honorary IMA National Professor in Neurology, and presently a consultant in neurology, serving the National Health Service in England. I'm a Kolkata Medical College graduate from 1990, and I have been training in neurology and practicing neurology in the UK since 1994. I would like to start this talk in a very somber mode because my thoughts and prayers go out to all the patients who are suffering in the second wave of the COVID pandemic, particularly that has hit India very hard in the last few days and weeks. And I'm sure we'll recover from it. And we just need to be careful, cooperate with administration to save countless lives that have already been lost and to prevent further suffering to humanity. I salute to all the COVID warriors and give them my support. Right. In regards to this talk, I have no conflicts of interest or financial disclosures. The outline of the talk of Parkinson's disease on this occasion, I have targeted it towards the MD students in the final years of their training, and knowing very well that there are not enough neurologists to look after all the neurological problems, all the MD internal medicine students and clinicians must be able to manage Parkinson's disease and atypical Parkinson's, thus for the next talk, in a confident manner. So I'll start off by talking about the neuropathology of this disease. I will next move on to talk about the classical clinical features. I'll be focusing very much on the non-motor symptoms of Parkinson's disease, which has evolved in the last 10 or 15 years and is now a part of the diagnostic protocol. I'll be touching on research. There'll be an element of genetics, which I'll not be covering in this talk, but there's a large number of genes which we are addressing in the Parkinson's disease. And I have a number of videos from various bodies, but please refrain from making records of the patients in honor of their dignity, privacy, and the confidentiality, because of them, we have learned to manage and learn about management of various medical conditions. With that, let's start with the anatomy of the basal ganglia. Just to remind and refresh yourselves, you can see out here the caudate nucleus, head of the caudate we can see. Then we have the globus pallidus and the putamen. That structure, P, is the putamen. And the globus pallidus is made of two parts conventionally, globus pallidus externa and globus pallidus interna. And here runs the internal capsule. Then we have the thalamus, which is the structure out here. In addition, we'll be highlighting the subthalamic body of Leis and the substantia nigra in the brainstem, substantia nigra. Up here, you can see, composed of two parts. Here is actually a diagram from the side, which shows you the orientation of these structures, the head of the caudate, body of the caudate, tail of the caudate, ending up in the amygdala nucleus. And these structures that you saw out here, referred to as the putamen and the globus pallidus, referred to as the lentiform nucleus because it's lens-shaped, is here. And more medially lies the thalamus. So there's an immense amount of circuitry that we'll be describing to you between the cortex, between the caudate cortex here, the caudate nucleus out here, the globus pallidus externa and interna, and the putamen and the thalamus, and then further projections to the substantia nigra and how they loop and exercise control. It is prudent at this point to talk about Braque's hypothesis about the evolution and about the pathogenesis of Parkinson's disease. Now, we know that it is a disease where there is depletion of dopaminergic neurons in the substantia nigra. Here you can see the control, where there's a lot of neuromelanin out here, the black coloration. Compare that in a Parkinson's subject, there's hardly any neuromelanin reduced in quantity. And you can see the lovey bodies. That's the hallmark of Parkinson's disease out here, lovey body pathology. And you can see how the neurites are forming out here. The Brack actually had the classification of the disease because his hypothesis was that the disease starts somewhere in the brainstem and then projects rostrally to involve the olfactory pathways. Further up, it will involve the lentiform nucleus. And then at more advanced stage, which is Brack stage 4, 5, and 6, it will involve the cortical projections. So that's how it starts and spreads, cortical lovey body. Now, there's also the other hypothesis as to the initial onset of Parkinson's disease, which is a synucleinopathy. Synucleinopathy starts in the autonomic nerve ganglia of the gut. So whether the disease starts in the gut and then spreads up the vagus nerve to involve the brainstem and goes up to involve the more cortical areas, or does it start up here and then spreads down the vagus nerve to involve the gut neurons? And I'll be talking about them as part of the non-motor symptoms. We will be discussing that in a minute. But there are certain contradictions, criticisms of the Brack's hypothesis, and to the interested, I will refer you to the papers by Reitik, Espe, and Werner Povey to discuss this etiology and the contradictions therein. No discussion of basal ganglia is complete without discussing the basal ganglia circuits. Now, there is a direct pathway, which is starting from the cortex through to the striatum, which is the cortex nucleus, which is D1 dopaminergic, D1 receptors, going on to the globus pallidus internal structures, and then looping into the thalamus to establish connections with the cortex. And this is the direct pathway I just described to you, which is facilitatory, which means when this pathway is affected, that's the hypothesis, then you get Parkinson's disease. Whereas look at the indirect pathway from the cortex to the striatum via the D2 receptors going on to globus pallidus externa, which I just showed you, into the subthalamic nucleus, and then making connection with the globus pallidus interna, and then looping to thalamus and into the cortex. This particular pathway, the indirect pathway coming down this way, is meant to be inhibitory. So when there is a pathology of this pathway, we get coliform movements. There is also another pathway, which is called the hyperdirect pathway between the cortex and the subthalamic nucleus, hyperdirect. And that basically acts as a checking mechanism for all these movements. This is something you definitely have to know as a neurologist and as DM students. For the MD, just remember this very simplified diagram. And this has got implications when you will be studying chorea or even dystonias, this circuit diagram and the relationship between the cortex, the striatum, the GPI, the GPE, and the STN. We haven't included the pedunculopontine nucleus in that. I think we have it here, the same diagram, but here we have included the PTN and the superior colliculus into the substantia nigra, which I didn't have in the previous simplified diagram, to give you a wider understanding of how the circuits of the movements control and regulate the movements. And from here onwards comes out the basal ganglia outputs. This is the internal regulatory mechanism. And to the interested, there are the papers from Cazorla in movement disorders. And this is again a further circuit diagram which goes about it. I think with that, we finish the heavy part, the science part and the physiology part. And this is now we come to what you see in day-to-day practice. So what are the Parkinson's disease cardinal motor features? It is a bradykinesia. There is a paucity of movements. There is also an asymmetric rest tremor. It starts off on one half of the body and then it over time spreads to the other side. So the asymmetricity makes it Parkinson's. There is a rigidity element, and we have all learned to examine rigidity from our third year days. In addition, gait and postural impairment, these are the other issues apart from the top three triads that we must also look for. So tremor, rigidity, akinesia, and postural instability make up the four elements that help us diagnose Parkinson's disease. So let me start off by showing you a video.
Sometimes you get no response from Cinemed, is that correct? And sometimes the latency from the time you take the Cinemed to the time you notice any improvement may take, what, an hour or two?
Yes, anywhere from 30 minutes to an hour and a half.
Okay.
The patient has classic signs of Parkinson's disease in his off state, including a coarse, pill-rolling tremor, stooped posture, hypophonia, poverty of associated movements, and masked face. He has difficulty getting up from a chair and can only take a few shuffling steps before flopping back down into his chair.
So your wife is now going to give you 0.5 milligrams of apomorphine. And could you stand up for me? Okay, and then walk back and forth, okay?
A subcutaneous injection of apomorphine ends his off state in a few minutes.
So there we saw how smoothly he was able to move after receiving his injection of apomorphine. I wanted to show you the levodopa responsiveness that is so very much characteristic of Parkinson's disease. If you want to see the video once again.
Sometimes you get no response from Cinemed, is that correct? And sometimes the latency from the time you take the Cinemed to the time you notice any improvement may take, what, an hour or two?
Yes, anywhere from 30 minutes to an hour and a half.
Okay.
The patient has classic signs of Parkinson's disease in his off state, including a coarse, pill-rolling tremor, stooped posture, hypophonia, poverty of associated movements, and masked face. He has difficulty getting up from a chair and can only take a few shuffling steps before flopping back down into his chair.
So your wife is now going to give you 0.5 milligrams of apomorphine. And could you stand up for me? Okay, and then walk back and forth, okay?
A subcutaneous injection of apomorphine ends his off state in a few minutes.
Right. So with that very interesting video we just saw, we pretty much see the whole spectrum of Parkinsonism. The cardinal manifestations you just saw was that he had a pill-rolling tremor. There was obvious bradykinesia. He was rigid, but that's actually a sign. And postural instability, I'll be showing you quite a number of examples. We'll not be able to show you much in way of facial expression because of confidentiality. We've blacked the faces out. Decreased eye blinking, hypomimia, hypophonia. We'll see that. We'll discuss dysphagia, phalluria, which is a non-motor symptom. There can be a lot of visual problems, eye movement disorders, hypometric saccades, impaired vestibular reflexes, upward gaze and convergence, although they may be a sort of overlap with the atypical Parkinsonian syndromes. We are all familiar with micrographia, dystonia. I'll be showing you a few videos. Myoclonus, stoop posture, camptocormia, we'll show that. And then there are difficulty in turning in bed and freezing, fascination, and gait. So that's pretty much the whole list of symptoms that makes a diagnosis of Parkinson's possible. So what's the course of symptoms? Now, this is basically going on the Braak's hypothesis of the disease starting off in the brainstem areas, and the autonomic nervous system being affected. So there is a history before the motor symptoms start of patients having constipation. And then there is rapid eye movement behavior disorders. Then there can be a smell deficiency and depression, mood disorders. And then only we get the bradykinesia, rigidity, and tremor. But along with that, there is evidence of pain, fatigue, and MCI, minimal cognitive impairment, leading on to levodopa institution. And then we get the fluctuations of levodopa response after about 8-9 years. And then there starts to creep in various different autonomic symptoms late in the course of the disease. And finally, there is dysphagia, postural instability, freezing of gait, and falls. And at the very end, when the cortical matter is involved, we get PDD, dementia, or psychosis. So that's the spectrum of Parkinson's, starting way before, 20 years before it's hypothesized. The motor symptoms that you see out here, the smell, the mood, the rapid eye movement, sleep disorders, and the constipation is the premotor or the prodromal stage, right? So this diagram again shows to you the Brack's hypothesis that I was talking to you about, the pre-symptomatic phase, and the pathological sort of substrates, the dorsal motor nucleus of the vagus. And then when we start to get the substantia nigra and the amygdala, the mood changes, then of course we get the thalamus and the mesocortex, and then the neocortex involvement. So that's how the disease spreads from the bottom to the way up here, along the olfactory routes, along the thalamus and the extrapyramidal substantia nigra, and then of course into the cortex to give the disease. Right. Now, so what's the brain bank diagnostic criteria, UKPD Society? Because the misdiagnosis is rather high in Parkinson's. As I'll be discussing in my second lecture, it's often difficult to distinguish the Parkinson's from the lookalikes. There must be bradykinesia, and then rigidity, tremor, and postural instability. I've discussed how the disease must start on one side, classically asymmetric with a rest tremor. It has to be progressive, and we saw the fantastic response to levodopa in Professor Joe Jankovic's patient, the video we saw earlier. And the clinical pathological studies, and there mustn't be any atypical features. Right, so here we want to tell you about the diagnostic criteria, MDS, Movement Disorder Society criteria for the definition of Parkinson's disease. Essential criteria being bradykinesia. That's the sine qua non of a Parkinson's, plus at least one of rest tremor or rigidity. And the patients must not have these conditions. So there mustn't be cerebellar abnormalities, because that will swing it to a different condition. There mustn't be any supranuclear gaze pulses. We have to be aware of the behavioral variants of FTD or primary progressive aphasias. If it's lower limb Parkinson's that starts with, it's more likely to be vascular etiology. Of course, drugs are very common. We must rule that out. And if the levodopa response is not there, then we are on soft territory. And then cortical sensory loss, we'll talk about CBD, corticobasal degeneration, in the next lecture. And if the DAT scans are not showing any deficiency, then that's another point against Parkinson's. And of course, the treatment response will be there, but it is there for other conditions which look like Parkinson's as well. And there is also the evidence of olfactory loss. You can see smell tests being undertaken for Parkinson's, and MIBG scans for cardiac denervation being seen. And of course, levodopa-induced dyskinesia is a feature, but then we are long into the disease process. We talk about the diagnosis for a prognosis earlier on in the disease process. Now, there are some research criteria for prodromal Parkinson's disease, because as you can understand, there's a lot of research ongoing to pick up the Parkinson's disease pathology very early on, because by the time the clinical motor features develop, 50% of the dopaminergic neurons have been lost. Hence, there is an emphasis on other autonomic symptoms, the premotor symptoms that we have to identify to get some disease modifying therapeutics into the clinical trials field. This particular case, I think, summarizes a good deal about the Parkinson's spectrum. He has had Parkinson's for about 7 years, right-sided, micrographia. He commenced on dopaminergic medications, got a bit better. Then he started having dyskinesias. Balance was getting worse. He was falling around. He was having freezing. And then he was having tremors, which then were worse when he was stressed. And then he was basically getting worse and worse. His sleep was terrible. And here you can see the rapid eye movement sleep disorder. And then as time progressed, he was having nighttime urinary problems and having to go to the toilet. And then he started having psychosis at night. And then, so you see there's constipation, there's involuntary movements, falls. So that's a typical case that presents to us, and that summarizes the whole spectrum of Parkinson's. So again, the same diagram that you've seen before. This is where we usually get to see that patient. The previous patient would fall into the territory of the motor symptoms, the fluctuations with treatment, and more symptoms indicating that the disease is advancing slowly. So we've talked about the unilateral rest tremor. We have seen how patients were moving their arms less, the spontaneous associated movements was less, reduced high movements, micrographia. As you keep writing, you can see the handwriting becoming smaller and more not decipherable. And including the Archimedes spiral that we are drawing out here also gets smaller. Don't forget, it can happen in the foot as well. You can get unilateral foot dystonia when you have, and often pain in one shoulder is often a Parkinsonian pattern, and patients have soft speech, hypophonia. Here we have a patient, have a look.
Okay, can you say, today is a nice day? Okay, could you try, ba 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 ba? Try, ba 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 ba. Ta 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 ta. Ga 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 ga.
Unfortunately, in this patient with advanced Parkinson's disease, you could see some hypophonia.
Okay, can you say, today is
the jaw tremors, the very masked faces that you have out here, but she was hardly able to say anything, virtually become muted. So that's again is marked hypophonia in a Parkinson's patient, advanced Parkinson's. Here in this patient, have a look.
A patient with Parkinson's disease has to try repeatedly to arise from the seated position.
So here you're seeing a severe rest tremor that they had, and very much difficult in initiating movements, cannot arise very quickly from the chair.
A patient with Parkinson's disease has to try repeatedly to arise from the seated position.
Rest tremors, difficulty in initiating movements, and postural instability. Here, look at the next patient about the tremors that you are seeing out here. There is a significant tremor at rest. It's slightly asymmetric, possibly symmetric now. It's an advanced Parkinson's disease. And just appreciate that as the patient picks the hand up, there is a huge amount of leg tremor, whole body tremor, and a postural tremor. Going on to the next patient here.
How old are you?
76.
And what bothers you the most?
My shaking.
How long have you had the shaking?
About 7, 8 years.
Do you think the shaking is getting better or worse?
Worse.
Could you hold your arms in front of you? Okay, next to your nose. Could you hold your arms in front of you?
Characteristic in Parkinson's disease. In this next video, observe what's happening out here in terms of the gait of a particular patient with Parkinson's disease. Moving around on the same spot, unable to initiate the normal stride very easily. And again here, you can see another patient turning around very slowly. There's a balance problem, so there's some assistance from the examiner. But the moment she tries to step forward, there seems to be an ignition failure. She's unable to get the step going to be able to walk. And you can see the struggle. She wants to start the movement, but this is hesitation, festination that you can see. Start hesitation, difficulty in turning as well. Here, the patient is being asked to go and sit down on the chair, and you can see how much difficulty she has in initiating the movement to be able to go back to the chair and sit down. Watch. And you can see the balance problem there. Here again, you can see this particular patient approaching the chair to be able to sit down there. Lots of tremors in both upper limbs. And you will see how she suddenly flops. She doesn't here, but there's a great amount of difficulty in being able to sit down. We have seen this postural instability and difficulty in turning. Can you see the small shuffling steps instead of taking one big turn spontaneously? There's so many small, short steps that the patient takes to be able to turn around a single point. And same here. Watch. Postural instability is what I'm emphasizing here. The rest is visible. The tremors you can see, and you've seen the start hesitation and the balance problem. The doctor stops the patient from falling over, and the great amount of anxiety the patient is exhibiting to be able to remain steady, all manifestations of imbalance. Moving on. So when patients become very advanced, their motor signs and symptoms also get worse. So basically, they will be having increased amount of motor fluctuations. The levodopa dose that they take starts off very well, works very well, but gradually with time, with the falling off of the dopaminergic neurons, there is not enough neurons to store the dopamine that we give to the patients. I'll be discussing this in the treatment lecture, but eventually there is a yo-yo effect. You can see when you start to take the medications, the symptoms are better. And then when the half-life starts to wear down, the symptoms start to return. And again, you give the medication again and you get a response. So this is a yo-yo effect that you start to get. So there's an on time when the patient is above that line, and off time when the patient is rigid, stiff, or having tremors or unable to go about their normal days. So increasing motor severity is taking place, fluctuations, wearing off, dyskinesia. At times it becomes unpredictable because the dopaminergic pool becomes, and the circuits I've described to you, start to malfunction. There are nighttime off periods, poor sleep, difficulty in turning, early morning akinesia. We have to give patients a tablet of dispersible levodopa preparations to start to get them to move. Freezing of gait, unfortunately, we understand very little. It's not levodopa responsive symptom. Again, the postural reflex impairment that you saw in the patients where they were very unsteady on their feet, and the falls, these are other symptoms for which there is no therapy, but there is a risk of falls. And then dysphagia, we'll come to that in a minute. Here you can see camptocormia or
difficulty
dystonia.
arising from a chair.
The doctor wants you to walk.
Turn around.
While walking, he displays severe camptocormia and right-sided pill-rolling tremor.
Okay, turn around.
His gait is otherwise not impaired.
Okay, turn around.
Right. So in here you see what is called as camptocormia, which is the forward flexion of the spine. It's a dystonia in Parkinson's disease. We also get lateral bending, which is the PISA syndrome, and the PISA in Italy. So these are things. So what happens basically in advanced Parkinson's disease is that we talked about the on and the off effects. Dyskinesia start to come in, whereas where patients have various different types of movements which are involuntary and related to levodopa dose. They can come on when the dose is too much, big dose dyskinesia, when the dose is off, and you can get them during the diphasic dyskinesia as well. And gradually the therapeutic window becomes smaller so that the patient starts having a significant amount of time in dyskinesia, which is not what the patient is able to carry out normal activities with. But it is better than being frozen and stiff and being unable to move. So there is advancing Parkinson's disease characterized by dyskinesia. Freezing of gait. What happens here, we saw quite a number of freezing of gait in the videos before, where the patient is basically suddenly there's a gait arrest and the patient is unable to initiate the walking phase again. It's like the battery of the car having gone flat, and then they require a cue. And I'll be showing you some cues that we use to get the patients to move. And this can be coming on during moving through narrow doors or passages, or when they see an obstruction, like a chair in the path, the patient freezes and then has difficulty being able to move forward. Here I am going to show you a freezing of gait. Watch.
The patient's upper limbs have normal volitional mobility.
Okay, now let me see you walk a little bit. Let me have you stand up for us.
Okay.
And try to walk to the wall there.
He is able to arise from the seated position with little difficulty. He stands with his feet far apart.
Try to raise my foot and go, or what? Like a...
No, just walk as you normally would.
He has difficulty getting going and freezes up while trying to turn, especially when trying to move his right foot. He needs to brace himself against the wall to regain his stability.
And keep coming back.
His arm swing is less on the right than the left.
Okay, now turn around and go back one more time.
Okay. This is where I usually fall down. And if I get started forward, lean a little forward, and the feet don't go, and then fall forward. There we go.
He freezes when he shifts his attention to the speaker.
Okay, and okay, so whenever someone talks to you, that really interrupts the walking. Is that correct? Okay.
Now watch. This is the cue that he's going to use.
When stepping over an obstacle, such as the protruding part of his cane, he can avoid freezing. Imagined obstacles may work as well.
Keep going.
Turn around and go back.
Yes, sir.
This way or what? I don't know. I gotta use it. Take a step over. That works. Sure does.
So that was a very good example of using visual cues to initiate walking. We do it all the time with laser pens that we use to help the patients to walk. Falls is very important in Parkinson's, senior symptoms, often having weak bones and having hip fractures. So basically, there is a lot of problems with falls. It's a real problem, and there's a lot of morbidity that is associated with it, particularly when patients have to get up at night to go to the toilet. And uneven surfaces, obstacles, poor footwear needs to be addressed. As you know, we don't have a treatment for falls, so a lot of prevention strategies. And this particular flow diagram that you have out here sort of addresses the issues that are put into place in a falls clinic to help patients with falls from Parkinson's disease, as well as from a large number of neurological conditions where the fall is a great morbidity. Now, in this particular video, watch. What you saw out here was basically the lack of postural balance when the patient is pulled from behind rather vigorously most of us should be able to take 1 or 2 steps and then stop. Whereas here, due to postural instability and lack of good postural reflexes, the patient tends to go backwards 2, 3, 4 steps, and eventually, unless you catch them, they will fall. This is a test that we have to undertake carefully as part of our clinical practice that exhibits lack of postural control or reflexes. Here is an advanced patient. See what happens. She's got rheumatoid arthritis as well. You can see the mask facies, the emaciation. The hands basically are rheumatoid, plus there's in addition some amount of dystonia. But look at the foot. There's a dystonia of the left foot, and we are trying to emphasize out here the striatal hand and foot. You get the striatal toe as well. Dysphagia occurs in Parkinson's disease in the late stages. There are other conditions we'll discuss, PSP and others where dysphagia occurs early. So that's a distinguishing factor. And mild oropharyngeal symptoms and esophageal dysfunctions are very common in the early stages, including sort of a collection of saliva in the back of the throat. So there's a need for speech and language therapy assessment and checking out the swallowing reflex, including by endoscopic evaluation or by video fluoroscopic evaluation. So dysphagia can lead to aspiration and definitely increases the chance of aspiration pneumonia or even, more mortality because of aspiration difficulties. Coming now to the non-motor symptoms of Parkinson's disease, this has been a growing phenomena which we have understood and put into a regular clinical practice in the last 10 years or so. The element of cognition, psychosis, mood disorders, sleep disturbances, fatigue, the autonomic function disturbances, olfactory dysfunction, the pain that patients describe, and of course the dermatology findings. These are all the non-motor symptoms in one list. And this is the same diagram again that I'm going to show you. Here we have marked off the non-motor symptoms, and there are non-motor scoring scales these days, like we have for research the UPDRS, which is the motor scales, which we have been doing for a long time. Now we have scales that estimate these symptoms, and they're part and parcel of the Parkinson's disease as the non-motor features. So here I have enlisted for you, again, the behavioral disorders, the sleep disorders, the autonomic manifestations of Parkinson's disease, synucleinopathies, the mesenteric plexuses, the myenteric plexuses do show synuclein over there deposition, thermoregulatory problems, and of course the olfaction, the visual system abnormalities, pain and posture and skin. So the non-motor symptoms are equally important as the motor ones because we have always impacted upon the tremor, rigidity, and akinesia, but we have not been addressing the other features which are equally morbidity causing in patients, and they present throughout the course of Parkinson's, the olfaction at the very beginning and the sphincteric disturbances and the psychosis and the dementia at the later stages. Unfortunately, there is no levodopa responsiveness. So we don't have therapy for it. And if we look at the study, 98% having at least one non-motor symptom, and that's the relative proportion of the various different symptoms patients report. And the most frequent domains were in the psychiatric domain, and you can read the rest. So depression, it's quite common, 40% prevalence. Premotor phase of PD, we've discussed that, and it has got to be asked for. Otherwise, patients often don't volunteer, particularly anhedonia and anxiety. Now, anxiety is a big issue in Parkinson's disease, but it is not recognized. Up to 40% can have it, and there can be PD with 2 anxiety disorders, phobias, panics, OCDs, and then non-motor fluctuations as well. Now, it can manifest as apathy as well, behavioral, cognitive, and affective symptoms, and can be a major cause for caregiver burden. Here in this Venn diagram, we can see the overlapping symptoms of psychomotor retardation, anhedonia, anergia, less physical activity than usual, and generally apathy or not taking an interest in the surroundings and environment, emotional indifference. Cognitive impairment will come on when the illness starts to impact upon the prefrontal cortex, the cortical region. So there can be a mild cognitive impairment, and of course, at a later stage, Parkinson's disease dementia. It can be heterogeneous involvement, subcortical at times, but then later on cortical, affecting executive functions, working memory, attention, visual spatial functions. Informant, the relatives will be the ones who will be giving us more information about the disease. We often attribute it to aging, but the functional impact remains remarkable. Here are some papers to address the cognitive changes in early and mild Parkinson's disease. Now, Parkinson's disease dementia and Parkinson's disease MCI, minor cognitive impairment, has been a research item for a long time as to the evolution of PDD and MCI in Parkinson's. Psychosis in Parkinson's is quite common. It affects at least 50% of patients on dopaminergic therapy. And there are little animals that the patient sees, non-frightening delusions and hallucinations, but there can be other. It's been classically described for a long time. Adds to morbidity. Now, there are other hallucinations that we talk about in drug-naive Parkinson's disease, but the more important thing is about the impulse control disorders. With the institution of dopaminergic treatment, dopamine agonists, a lot of impulse control disorders were first time diagnosed, leading to a lot of litigation because patients were not counseled about pathological gambling, compulsive shopping, hypersexuality, and binge eating. So there's a disturbance in the reward mechanisms within the brain, giving rise to repetitive performance of the same task to seek the reward-seeking behavior. And addiction history, dopaminergic agonists, as we said, we routinely have a questionnaire that we have to administer before we can start the patients on treatment. And patients will often report, and their carers will report that they have an urge to take more and more of the dopamine agonists to be able to go about this. Fatigue. In Parkinson's, there's an overwhelming sense of tiredness, lacking energy, feeling exhausted. It's very disabling in Parkinson's. Again, a non-motor symptom of Parkinson's. This is a peripheral muscular fatigue, but there can also be a central element from the basal ganglia circuits which generate the movements. Sleep disturbances, we talked about the rapid eye movement, sleep behavior disorders in that patient's history of primary sleep disturbances with insomnia, restless leg syndrome, sleep apnea. The REM sleep behavior disorder is the most commonly described. There is akathisia, poor mobility, and then there is excessive daytime sleepiness, plus the medications that give rise to hypersomnolence and thereby become a risk during driving in particular, and there can be car crashes. So that's another slide which tells you more about the REM sleep behavior disorders. It was found in 86, and then you can read the paper. Autonomic symptoms we touched upon earlier to do with the cardiovascular autonomic nervous system. Hence, we saw their IBG scans, gastrointestinal and genitourinary and thermoregulatory disturbances, all through autonomic nervous system disturbance. A significant quality of life, particularly constipation, orthostatic blood pressure, becoming dizzy when they suddenly stand up, and then having to go to bed, having to go to the toilet at night from nocturia. And then constipation particularly is a big problem because of delayed colonic transfer, and that often gives rise to incomplete absorption of levodopa preparations and thereby prolongs the off states in diseases. And then genitourinary symptoms, we talked about the frequency, the incomplete bladder emptying, the incontinence, and this is because of, again, the autonomic nervous system disturbances, including sexual dysfunction with erectile dysfunction and changes in libido. Orthostatic hypotension, defined as you all know, 20 systolic, 10 diastolic, prevalence quite high because of cardiac sympathetic denervation or because of other autonomic nervous system dysfunctions, plus the contribution of PD medications, levodopa, And in Parkinson's, these will happen much later in the illness, whereas in MSA, we'll get these earlier. We'll discuss that later. Sweating disturbances, excessive sweating, intolerance of hot environments, flushing, hypothalamic dysfunctions. And again, there's not much in way of treatments. The musculoskeletal issues, we have shown you pictures of camptocormia, disproportionate anticolis, PISA syndrome, scoliosis, that's the PISA syndrome for you, lateral flexion of the spine. And then, of course, there is seborrhea, oily, flaky skin, inflamed skin, dry skin, too little perspiration. That's an amantadine side effect. So I have tried to present to you the spectrum of Parkinson's disease, starting off with the physiology, the pathology, the circuitry, then the clinical features. Motor symptoms we've all been brought up on. It was the non-motor symptoms that I wanted to emphasize upon you. And then again, the entire spectrum that is Parkinson's disease. It's rather a complicated business because we're still uncertain about the true etiology of the Parkinson's disease. You can see the synuclein hypothesis playing out here, the oxidative stress out here. There is, of course, a huge amount of genetics that I'll not be covering out here in the genetic elements of the Parkinson's disease. And then there are other sort of protein deposition abnormalities. To the interested students and postgraduates, I'll recommend to you the article from Joe Jankovic, which describes the complexity of the pathogenic mechanism of Parkinson's disease. And again, from the etiopathogenesis and treatment points of view, another paper from Professor Joseph Jankovic, whose slides and videos from patients I showed you with his commentary. And this is a 2020 paper where you can look at the genetic risk factors, the risk variants, the pathogenic gene mechanisms, the epigenetic risk factors, and the environmental risk factors, and then the lifestyle influences on Parkinson's disease, all of which make the disease a very much of a research opportunity for many, many decades to come. So I think in summary, I've tried to emphasize upon you that in Parkinson's disease, there is movement disorders, which we have classically understood it to be, but there's a large number of systems, making it really a multi-system disorder. It's not only a movement disorder, it involves so many other compartments. And there is an early stage which precedes the motor symptoms by 20 years. We saw that. And it requires a comprehensive and interdisciplinary approach because apart from levodopa and the dopaminergic pathway manipulations that we have at our disposal, and some surgical remedies we have in terms of deep brain stimulation, where we alter the circuitry of the indirect and direct circuits that I spoke to you about with stimulation, there is no real treatment for the non-motor symptoms apart from symptomatic therapy. So over there, we need to be making more progress to be able to understand the problem better and relieve the symptoms. And it is said that Parkinson's disease will be increasing in number with increasing diagnosis and will call out for treatment and help from physicians across the board in India and rest of the globe. Right, I wish to acknowledge for the videos and the materials I have used in this particular lecture from Meddling Neurology, those from Professor Joseph Jankovic's collection. The American Academy of Neurology have taken some materials from there, as from the International Movement Disorder Society. Some slides I have borrowed from the Aspen Movement Disorder course of Dr. Jennifer Goldman. Up to date, I've used some materials and the recently published Neurology in Clinical Practice, which is one of the standard textbooks of neurology for all of us, 8th edition. These are my sources of information in being able to present to you my lecture today. Well, thank you for listening and best wishes till next time. I'll be coming back with 2 more lectures in this series. Long live IMA, and my thoughts and prayers lie with the patients of COVID in India and rest of the world. And I hope Almighty God blesses us and we win this battle very quickly against Corona and we are back to our normal times. Thank you very much. And thank you again for listening. If you have any questions, I'll be happy to address them on email, but good reading and good research and progress and educate your next generation. Thank you very much.